On behalf of the Council of the Ghana Academy of Arts and Sciences, I welcome you to this year's GAAS Public Forum, which starts today and ends on Wednesday, 5th June 2019. You are most welcome to this program. Before I proceed to introduce our chairman, I'd like to briefly talk about the GAAS Public Forum, which dates back to 1993 and has taken place in June each year without any interruption. Some of the topics that have been dealt with are in the booklet, so you could have a full list of what has been dealt with over the years. Eminent scholars are normally invited to participate in the program, and it's expected that the proceedings of the symposia will be published shortly. For today's program, we are honored to have MTN Foundation sponsoring it. Thank you very much. At this juncture, I would like to introduce the chairman for this evening's event. Professor Henrietta Mensa-Bonsu is a professor of law at the Faculty of Law, University of Ghana. She is also the immediate past director of the Legon Center for International Affairs and Diplomacy, and was the Deputy Special Representative of the Secretary General in Liberia in 2007. Professor Mensa-Bonsu is the President of the Academy. Please help me to welcome the chairman for this occasion.
Thank you very much, Honorary Secretary. Past Presidents of the Academy, Vice Presidents of the Academy, Fellows of the Academy, distinguished ladies and gentlemen. Of course, that includes the students. You are gentlemen, aren't you? Welcome to this year's forum. Every year, as the Honorary Secretary has told you, the Academy takes a topical subject and organizes a symposium on it to hear various views and aspects of the problem. This year, we are looking at non-communicable diseases. Sometimes when there are disease outbreaks, we make a lot of fuss about them. But those that are really killing us, the non-communicable ones, are very quiet. Perhaps because most of them are lifestyle related, and we are all guilty of living in ways that don't help our bodies. We are normally quiet about them. But we risk leaving a lot undone, leaving our young people at the mercy of some of these avoidable consequences of morbidity and mortality because of our silence. And so this year, we are going to take a look at these matters, and they will be building up from day 1 up to day 3. We will begin today under the sub-theme, the burden of chronic diseases. And it is my pleasure to introduce the first speaker, Dr. William Bosu, West African Health Organization based in Burkina Faso. Dr. Bosu is currently the technical advisor responsible for non-communicable diseases, eye health, mental health, and nutrition at the West African Health Organization, the specialized institution of ECOWAS, with a mandate to promote and guard and safeguard health of ECOWAS citizens. He has many years of experience in policy, programming, and research, especially in the field of non-communicable diseases. Between 2004 and 2012, he was a program manager of the National Non-Communicable Diseases Prevention and Control Program of the Ghana Health Service. He has worked as a clinician, a district director of health services, the head of regional health research programs, and a deputy director of public health, all in the central region of Ghana. Between 2003 and 2012, he also did some teaching. He was a part-time lecturer in advanced epidemiology and disease control at the School of Public Health, University of Ghana. He is a fellow of the Ghana College of Physicians and Surgeons and a fellow of the West African College of Physicians. His research interests include, of course, chronic non-communicable disease risk factor surveillance, hypertension, and monitoring and evaluation of health programs. Dr. Bonsu, your audience.
Madam Chair, eminent fellows of the Ghana Academy of Arts and Sciences, eminent professors, ladies and gentlemen, it gives me much pleasure to have been invited to participate in this year's annual forum. And I think that looking through the leaflet as we have it, and as the President mentioned, every year there's a theme. I was struck to find that non-communicable is one of the first health issues that are being tackled by GAAS. And I'm hoping that through the presentation, we will all get to find why it's such an appropriate intervention by the Ghana Academy of Arts and Sciences. One can only hope that with the might, with the academic cloud behind the Ghana Academy of Arts and Sciences, having non-communicable as a theme, really press the right buttons and manage to influence policies as much as possible. I have struggled a little bit looking at eminent professors who know everything. I risk boring them if I merely repeat what they already know. And on the other hand, looking at our young ladies and young men in school uniforms, you really must carry them along. So I think that I'll really defer to our young ones. So I apologize to my professors if they find that I'm boring them too much with what they already know. What I really intend doing is to introduce what non-communicable diseases are and focus on 10 key messages. I'm changing the slides myself here. Okay, fine. So I'll focus on 10 key messages and just conclude. Madam Chair, typically we define non-communicable diseases by what they are not. Basically, they are not communicable diseases. In other words, they don't spread from one person to the other by the typical means that we know. So from dirty hands, from sexual intercourse, those kinds of things, or from vectors, from mosquitoes and so on and so forth. And we tend to group them into, there are several diseases that qualify as non-communicable diseases. So in the WHO report of 2005, they listed these diseases. You have disease of the circulatory system, endocrine, nutritional, and metabolic disorders, malignant neoplasms, chronic obstructive pulmonary disease. Don't worry about these big terms. The first one that you see just means hypertension or stroke, okay? And when you hear endocrine, just think of diabetes. And then neoplasms just refer to cancer. So we have hypertension or cardiovascular disease or stroke, and then we have diabetes, we have cancers, and then we have asthma. I have listed other diseases. The top 4 tend to be the common when we talk about non-communicable diseases. Those are the ones that we typically think about. But we also have oral diseases, musculoskeletal disorders, so the aches, the rheumatism, the aches and pains, they all form part of the sensory, ear, deafness, all of them form part of this non-communicable diseases. And when you hear hemoglobin, you tend to think of the red blood cell. There you are thinking about sickle cell disease and then the whole area of mental health. So in other words, non-communicable diseases, the scope of non-communicable disease is really wide and not just what we tend to typically think about as stroke, diabetes, cancers, and so on. Okay. So having said that, the first key message that I like to say is that although they are called diseases, and although they are non-communicable diseases, and although in the Millennium Development Goals between 1990 and 2015, non-communicable diseases were not explicitly stated. Non-communicable diseases actually significantly impact socioeconomic development, particularly in our setting. Why do I say that? Well, in 2012, the World Health Assembly met and identified 9 global targets. So the overriding target is really reducing premature mortality from non-communicable disease by 25%. And there are various other, like physical inactivity, reduce it by 10%, tobacco use by 30%, and so on and so forth. So if you like, coming from the 2011 UN General Assembly on special session on non-communicable diseases, this global push momentum really galvanized efforts to move countries together towards the control of non-communicable diseases. We had targets that all countries signed up to, and hopefully we are all moving towards attaining some of these targets. Now, as you know, beyond the World Health Assembly 2012, we've had, after the Millennium Development Goals ended in 2012, we've had the Sustainable Development Goals, which lead us up to 2030. And here, the target for non-communicable diseases is really to reduce the burden of non-communicable. So we had 25%, but in 2015, it was even upped. The game was even upped a little higher. So the target is to reduce non-communicable disease deaths by 1/3 by the year 2030. In health, for those of you who know about the Sustainable Development Goals, there's one big goal, which is this good health and well-being. But just to make the point that non-communicable disease is not just about health, it actually impacts all of these, wherever you see a star. So clean energy, there's non-communicable disease, the economic growth, all of that, all of these impact non-communicable disease, or non-communicable disease impacts them, inequalities. And Dr. Lai will talk a bit more about the economic burden. But just to say that non-communicable diseases have the notorious habit of, because they are chronic, because many people suffer non-communicable, the first time they know about non-communicable disease is when they suffer a catastrophic event. So somebody has hypertension, you say it's a silent killer because you have it, you don't know you have the disease. Suddenly you have a stroke, and that is where you know you have hypertension, or diabetes manifests as some complication. Suddenly they have to cut off your leg and so on and so forth. When these things happen, you can imagine that they impact really catastrophically on the spending at the household level. So they are able to tip you into poverty by their catastrophic nature, and because they run a chronic course. It's not like malaria or pneumonia where you give antibiotics, they go. This one, you live with it. So they actually maintain you in poverty. So we need to look at non-communicable disease beyond the hospital. It's not, they are not a set of diseases that belong to the hospital, but they have ramifications on various aspects of the economy, as exemplified by the Sustainable Development Goals. The second point I'd like to make is that the burden of non-communicable disease. I think that's a key reason why, or one of the key reasons why non-communicable disease were selected as a theme. The burden is generally increasing in Ghana. We've known this for quite some time, for decades. Unfortunately, it's so much easier to talk about it. I'll talk about political will later, but you realize that when politicians stand on stage, it is not the hypertension or diabetes. It's not interesting to be talking about these when you have HIV to talk about, maternal mortality to talk about, reduction. Those are the things that sort of, win votes. You seem to be doing something for health when you're talking about these important tuberculosis and all that. To talk about sickle cell disease or diabetes, really. And if you think the medical evacuations that happen, what tends to really move our presidents or our MPs when they go abroad for treatment, it's not the malaria, it's not the pneumonia that takes them away. It's the non-communicable diseases, it's the cancers, it's the kidney something, you know, these difficult diseases that are costly and if you like, they are difficult to cure in our settings. And so you think that our politicians are leaders because they tend to be more affected by it. They will take this and run with it, but that's not what we see. So in the pattern we see in Ghana is that 43% of the deaths, and these data come from the global burden of disease, that if you look at all the deaths that occur in every year and you categorize them by cause, then you have about 43% of them coming from non-communicable diseases. In fact, if you took the trouble year by year to standardize, there's something called standard, because age distribution changes from year to year. If you're comparing and said, okay, I'm comparing 2 time periods, I don't want the difference in the non-communicable disease burden to be due to the age. So let me find a way of making age constant between that time period. If you did that, you actually find that non-communicable disease is a leading killer. It kills more than the HIV and TB and so on that we make more noise about. So these are other countries in West Africa. So we have Cape Verde. Cape Verde, their life expectancy is just like Europe. I mean, they're 85, 80. They live quite long, and they tend to have a lot of non-communicable diseases. And you see Ghana and then Senegal, Togo, Cote d'Ivoire, Benin, Guinea, and so on and so forth. But just to say that if you look at the burden in relation to other West Africa countries, Ghana, we day inside a little bit. Okay, the other thing I like to mention for the burden is that the same global burden of disease has a league table that it does. So if you compare 2 time periods, for example, compare the period from 1990 to 2017. This is so much nicer on my screen than here. Okay, any light blue that you see is really non-communicable diseases. So trust me, this is cardiovascular disease. It was 4th ranked. This is looking at all the ages in Ghana as a percentage of death. You see that 1990 was ranked number 4, but by 2017, it had gone up to be the leading killer. All the other diseases, so cancers, neoplasms are the same as cancer, it's gone up, diabetes has gone from 14 to 8. Generally, you see the relative importance of these non-communicable diseases in terms of death. Their relative burden has increased over this period. And if you ignore the fact that these data don't tend to be the raw data that we deal with, they tend to be based on some models and so on. Our own local statistics. So this is the report from Ghana Web or Star FM. Hypertension is the leading cause of death at Kofodia Regional Hospital. In other words, those data and those arrows, they are not something far away. Our hospitals, if you look at the list of the leading cause of diseases, you find hypertension there. It's the leading cause. If you look at the outpatient, in terms of outpatient, 611,000. So the first time anybody newly goes to an outpatient clinic in a public facility is going 611,000 last year went because of hypertension for the first time. So these are new cases. And these data even exclude Konfanochi and Kolebu and some of these big hospitals. So they in terms of numbers, they are really there with us. Explain a little bit more what the numbers mean. It's estimated that there were 200,000 deaths overall from all causes, out of which about 90,000 were due to non-communicable diseases. And if you break these numbers further, these are 2 time periods, 1990. You see that cardiovascular disease increased from 16,000 to 36,000. This is looking at it as a proportion of all the diseases. So you said about 20% of all deaths that occur in Ghana, regardless of how old you are, is due to cardiovascular diseases. Remember I said that 43%. Now within that 43%, or if you look at it as a whole, you find that cancers constitute about 9% of all the deaths that occur in Ghana, and these are the other breakdown. In the beginning, I mentioned that non-communicable diseases were wide. So you had musculoskeletal disorders, oral disorders. But here, what I've done is just to look at these 4 common diseases, the major diseases. And you find that the 4 major diseases alone in Ghana account for about 76% of all non-communicable diseases. So it's quite fair even to be talking about non-communicable in terms of just the diabetes, cancers, asthma, and cardiovascular diseases. And that percentage has also increased from 70% in 1990 to 76%. So you're seeing this increase in non-communicable diseases from different data sources. Okay, so recently there was a, how do you explain meta-analysis? Okay, there was a study that brought together all the studies in hypertension, on diabetes that have been done in Ghana. And there were about 12 of them. And those who did the study listed all the publications, so there's Professor Amwa, Fred Vuvor, and so on and so forth. And these are the prevalences that they found. The statistics, they have a way of combining. When different studies have been done, there are various statistical attributes. You can't simply add them and say, oh, 1 plus 2 plus 3, this is the average, and therefore this is what the figure is for Ghana. There's a way in which they are combined, and when you combine them, what they found was the prevalence was about 6.5%, okay? So this is just something that has recently come out. So about 6.5% of adults in Ghana have diabetes, okay? These are community-based studies, or most of them were community-based studies. So they are not people who are sick or look ill. They are minding their own business. You ask them to fast, to take their blood sugar, and you find that it's above the level where it's normal. So I just added a few notes to say that when you look at some of the studies, actually, some of the studies relied on self-reported diabetes. Some of them relied on diabetes in pregnancy. Some of them they had a World Diabetes Day, so they rang bell, dongomi, come, let's screen you. When you do that, people who are health conscious, people who may be suspecting that they may have diabetes will come, and lo and behold, when you test, they have diabetes. So when you put all that together, it may well be that you are exaggerating the true level of diabetes within the community. I hope this is not too high above your head. I'm trying to be as simple as possible. But basically, if you ignore the little problems with some of the data, what seems to be emerging, that about 6.5% of our adults in Ghana have diabetes, okay? Okay, so you see we are taking some of the big diseases in turn. I think we now want to talk about cancers on the whole. So according to WHO has an agency that is responsible for cancers, and they estimate that we had about 23,000 deaths from cancers in Ghana in 2018. And what you see here is just a pie chart of what are the components of these different cancers. You find that about 20% of it is breast. So breast cancer is the new cases of cancers that we see. The number 1 is breast cancer, and then you have cervix and so on and so forth. Okay, but about 23,000. And then if you look at deaths, although I said breast cancer, when it comes to deaths, the deaths are the red bars. You find that cervical cancer tends to kill more than breast cancer, followed by prostate, liver, and so on and so forth. Okay, so now it's the turn of asthma, and that's the last one of the big 4 diseases. It's just to say that we don't have very much, unfortunately, of all the diseases, the asthma doesn't get studied a lot. So this was a study that was done in 2003, and then in 1993, they went to the same school, 3 schools in Kumasi, one the university, one other, some Saito-like school, so not high level, and then one at Ohim, 20 kilometers, so it's on the periphery of Kumasi. And what they found that in 1 year, they can't measure asthma as asthma. These are not sick people. So to find asthma, there's a way in which they will let you exercise, and then they will see whether your breathing is breathing well. They will prick your skin and see whether there are some fields, there are some bumps that indicate that you could be having asthma. So there are indirect ways of measuring asthma. And if you did that, what you can say is roughly, they found that there was an increase from 3.1%. The highest was in the rich school, the university primary school. And by 2003, it had gone to 5.2. If you looked at the atopic center, it just means skin. When they tested your skin, it had a manifestation that suggested that you may be having asthma. Also, there was an increase over this 2-time period. Again, roughly suggesting that we may be having asthma that is going up. It doesn't mean this is just one school. It doesn't mean that is the truth, but you can only go by the data that you have available. So all that was on the second point, and I have 10 of them. Many of them not much, but where we have to talk about burden or risk factors, I'll talk a little bit about, I spend a bit more time on there. The third point, Madam Chair, is the fact that the burden of non-communicable disease that we have, we find that a lot of them have complications already. And we find that the outcomes, those who suffer non-communicable diseases, to try to be diplomatically correct, we say the outcomes could be better. It's difficult to say the outcomes are poor, because, I mean, it sounds like you're judging, but definitely the outcomes could be better. And this doesn't mean it's a health service factor. It could be factors in the community on the part of the patient himself or herself. And a few examples to illustrate this. You find that there was cervical cancer, 821 diagnosed with cervical cancer in Confanoche. And out of this, between 2010 and 2013, you find that about 60% of them died during follow-up. At 3 years, 39%, only 39% had survived. So a lot of our cervical cancer cases, same with breast cancer, in fact, indeed, all the cancers, they come very late when there's very little that we can do for them. So that's what I mean by we have complications. When these cases come, they have complications. And in fact, those who did the study went on to do some further analysis. In fact, that if you had had some intervention, surgery, radiotherapy, the hospital, the doctors had done something, your survival was better than those who had other kinds of treatment, which were the other kinds of treatment that were inferior. In another study, what we found was that in various studies on cancers, from Professor Poby's days, only about 24% of people who have cancers on hypertension are aware that they have hypertension. So like you sitting there, we measure your blood pressure, then we ask you, has a health person told you that you have hypertension before? You say no. And then you find that the awareness is very limited. There are people, and you see, for hypertension to cause a complication like a stroke, you don't have to know. It just happens like that. So it's useful to be checking our blood pressures and so on and so forth. And as I will demonstrate, even among health workers themselves, we don't really go for medical checkup. But just to say that our best, even among civil servants in Accra, you know, civil servants, you normally would have had medical exam screening before you're employed. Only about 55% were aware that they had hypertension. By the time you're looking at how much of this hypertension is controlled, to say hypertension is controlled means that it's reached a level that is not really linked to complications. You are sort of stable. And you find that our best hope is about 13%. So most of the people in the community, so you step out onto the street, the people who have hypertension in the community who need treatment, whose blood pressure levels need to be brought to a level where they can live comfortable lives, less than 13%. And yet, you know, I remember we did a survey in the there was a lady somewhere in Mamprobi selling actively and so on. It was like, is this one's pressure correct? Okay, relax. We gave her some time, tested it was 200 and something. Hey! So we have people with very high blood pressures. We say it's silent killer because it doesn't manifest, and yet they are living with all these complications until it strikes them as an emergency. Okay, so this was the study I was referring to a moment ago. So in civil servants in Accra, 30% had hypertension. Out of this hypertension, 20% already had severe form of it. They were not sick. They were working. They had gone to work normally. They were randomly sampled. 20% had a severe form. And already out of those with hypertension, about half already had evidence of target organ damage. Means that the hypertension, they had lived with it. It had some effects on their eye, on their kidney, the heart, and so on. They already had some complication on their eyes. So diabetes was also common, 9% in this group. Okay, so complications. Again, if you look at the Confanoche, they did some plenty series. 59% of them had complications. The diabetes clinic in Confanoche, for a 31-year period, over time, they found that about every year, basically, between 15% and 30% died every year from diabetes. So that's what I mean by complications are common and the outcomes are not as good as we would have liked. And unfortunately, awareness is low. In fact, it contributes in part to why we have these complications. Awareness is quite low. There's irregular medical checkup. As an example, Professor Amoah's study in Greater Accra region, those who had diabetes, only 70%. Only 30% were aware, had previously been told that they had diabetes. So you have 70% who were not aware that they had diabetes. And you think that people who are workers, especially media, the media like criticizing, they like projecting and so on. So these guys did some study. Dr. Edu and so on did some study among the media, large organizations. And asked them, which of you has previously been diagnosed to have hypertension? They got 32%. Okay, so with that 32% of them who self-declared, that is already quite high, who said they had been told. So the researchers then went on to actually do the measurement. When they did that, that 32% had gone to 60%. Just to say that people have hypertension that they are not aware of. So the awareness is low amongst us, and as I said, the risk is always complications happening. So my favorite example about health workers. So University of Ghana just here, College of Health Sciences, these are health experts. So average age 40 years, 34% of them have hypertension. Okay, that's already quite high. But only 44% of those were aware. These are health workers. Only 44% were aware that they had hypertension. If somebody should know they have hypertension, they are the ones measuring the blood pressure, they are the ones talking about it, and yet they didn't know. So that gives you an indication that really the awareness is quite low within the system. So you talk about overweight. So 43%, the College of Health Sciences, they are quite endowed. 43% were overweight, 13% were obese. But you see, there were those who did not consider themselves overweight. They had the body size and so on of somebody who was overweight, obese, and yet 37% of them were actually overweight that they didn't know that they were overweight. So if you're overweight or obese and you don't consider yourself as such, you wouldn't do anything about it, and yet you may have the consequences of that. Okay, so this is Professor Clegg Lamte's slide, famous picture, as acknowledged here. By the time they come to the hospital with a breast cancer, it's already too late. But there have been studies in Komfanoche and Kolebu where they found about 60% of them, they came in late stage. Medically, Professor Akosa will explain all this to you for those who want further information on it. They come in late. The same thing in another study, Professor Yabua also found that 85% of those who have hypertension come in late. Now, the fifth message, Madam Chair, is the fact that younger people are more often affected than is realized. We tend to think that as for hypertension, you're an old man, you're an old lady, you are nearing death, and so on. No, actually, younger people the age of onset is declining all the time. Why do I say that? Okay, so in Komfanoche and in Kolebu, they looked at a series of patients with cervical cancer and found that the youngest of them was aged 11 years, and the oldest was 100 years. If you take a mean, their average age was about 57 years. We used to think when growing up, as for cancers, they are like 80 years or if you are lucky and you are still alive then, otherwise you'd have died long ago. And then in Dr. Ebua's case in Komfanoche, the mean age, the average age was about 49 years. In our system, 49, still you're young, okay? And a study was done in the Jamestown area here among poor young adults. They came from poor households, monthly salary very low. So if you thought that hypertension was something, a disease of that rich people were older, this survey found that already with a mean age of 31 years, their salary, I forget what the figures are, but very low. These are poor slum areas of Accra. And already 28% had hypertension. 28%. with a mean age at 31 years. And then several studies, not too many studies, found that in school going children 9 years, 15 years, JHS, earlier SHS, up to about a quarter of them are already overweight or obese in urban centers. So the young people have problems. It's that the non-communicable disease, the burden is not only in the old people. And WHO estimates that those 4 diseases that I talked about, the probability of dying between the age 30 and 70 years in Ghana is about 21%. It's about 21%. Here, Ghana, okay, the probability is lower than some of these other countries, Sierra Leone, Cote d'Ivoire, all the way to Cape Verde. So Cape Verde is interesting. Although the proportion of death is much higher, the total death, they survive more. So a lot of them are getting diabetes, cancers, and so on, but they survive. But these other countries like Sierra Leone, it may be low, but if you get it, you die. So that probability, 30 years, 70 years is quite low. The 6th message I'd like to convey, Madam Chair, is the fact that the risk factors are mostly Western, they are multidimensional, they are multisectoral. And what do I mean by that? Okay, so these are the common risk factors: obesity, smoking, alcohol, and so on and so forth. Again, our famous chart. The other one was about diseases. These are about risk factors. If you look at the risk factors, high systolic blood pressure just means is a way of saying a type of high blood pressure. It's the number one leading cause. When I was talking about standardizing, that's if you remove the effect of age or reduce the effect of age from 1990 to 2017, the leading cause of death has been high systolic blood pressure. Even diabetes, high fasting blood glucose. Its ranking it increased from 7th to 3rd. So even with the risk factors, they appear to be increasing. Now we come to obesity. What does obesity tell us? So there was recently a publication that looked at countries that had done, we have a demographic and health survey, where they had data for at least 5 points or 5 time points. And what you find is that countries that had were Benin, Burkina Faso, Cote d'Ivoire, Ghana, Guinea, Mali, Niger, Nigeria, and Senegal. In all the countries, obesity among females in urban centers were on the rise. But you see, Ghana overshadowed them. We were the tops. The females in urban center tend to be heavier, or they tend to be bigger than in most of the other countries. This is the same thing, looking at it in a bit more detail. That if you look at female overweight or overweight from the DHS surveys from 1993, the 5 time points, that you see that overweight obesity is made up of this part is overweight, this part is obesity. If you just take the part about obesity, this tripled. It went from 7.7% to 22%. It doesn't show on this one. So obesity alone has tripled if you take that component. But what you see here is that if you add this 30 plus 22, more than half of our women in urban centers in Ghana are either overweight or obese, and that has problems. In a study that was done in Accra, what they found was that if you look at the obesity, already was quite high, 62% overweight obese in Accra in 2000-2003. The same location, they went again, it had gone up to about 65%. So overweight obesity seems to be a problem among women in the urban centers, or among residents in the urban centers. And perhaps it's not entirely surprising because our environment is obesogenic. What does that mean? It induces obesity. When you have a lot of women in the market sitting, surveys when you go around, there are a lot of fries all over the place. We are frying yam, we are frying the plantain everywhere. And sugar sweetened beverages are all over the place. So our sports, our drinking areas, you have some sweetened beverages. So the malls, the Coca-Colas, all the sweet things that induce obesity. When you look at the risk factors for hypertension itself, well, it tends to be in older age group, people who are richer, people living in urban centers, and so on and so forth. If you look at the risk for diabetes, then there's family history. If you're overweight, all of these, you have a higher risk than those who are not overweight. So when you're older than 40, when you're physically inactive, these are all risk factors for diabetes. The only area where we've been doing quite well, and I was sharing something with Professor Akosa a moment ago, that really, I think one of the success stories in the area of tobacco control has been this leadership, galvanized. Many of you remember that when Professor Akosa was the head of the Ghana Health Service, there was hardly a week that went by without some throwing some missiles at the government for not passing the law on tobacco or dealing with some organization or some sort. So for tobacco, we seem to have a success story that it has declined from 9% in 2003 to about 5%. It has decreased over this period. And this is looking at smoking in men. The only problem is that when you look at it from the point of view of socioeconomic class or wealth quintiles, then you find that those are the poorest households. Yes, the poorest household in 2003 has been declining, so it went from 15% to 5%. But for the richer, in other words, the poor people, the people from the poorest households the smoking is more common amongst them. But if you looked at the data for 2014, this 9% in the poorest household, this is less than 1%. The difference is 15 times. Okay, in other words, in plain English, those people from the prevalence of smoking or the practice of smoking among men in the poorest household is 15 times that you find in the richest households in Ghana. I've been talking about the separate risk factors, but just to say that the risk factors often come together. So in the Greater Accra region, for example, about 60% have a package of you're either physically inactive, you're smoking, or you have high blood pressure or something. We're presenting these risk factors as if they are by themselves, but actually they cluster, they come together, and when they come together, they potentiate the effects of one another. Okay, the seventh thing is to say that the seventh message is that the major risk factors are not only in the health sector. I think that I've drawn examples on this, so I won't belabor the point. I'll just run through this. What are some of these contributory factors? Okay, so these are my favorites, my favorite slides of P. The causes: political commitment, political commitment, political commitment. I started off with that. The politicians don't like talking about what kills them. They like to talk about malaria, family planning, and less about the diabetes and so on. We need this political commitment. If you look at the budget that goes to prevention and control of non-communicable diseases, and you compare that with HIV, AIDS, or malaria, it's a huge gulf. It's important to have policies, plans, and programs in place, and these have to be coherent. So you find, for example, in the Ghana Health Service, the nutrition department has its own plan, and often the nutrition plan is more towards undernutrition. But you think that because we are what we eat, if there's a nutrition plan and there's a non-communicable disease plan, they will talk to each other, so that nutrition will be talking about salt reduction, non-communicable will also be talking about salt reduction. There has to be that coherence across the different sectors. Processes. The agriculture emphasizes quantity, so grow quantity. As for the nutrient value, it doesn't count very much. Let's produce. We want to sell. But fortunately, with the efforts of FAO, the agric, it's changing. So it's both the quality and quantity. Oh, profit. Profit is the name of the game. I mean, despite what if you watch the UEFA Championship 2 days ago, it's Heineken, it's Pepsi Cola. If World Cup, Ghana wants to go to World Cup, it's on Pepsi Cola or Guinness or something, or Adonko Bitters. I mean, they are all over the place. They have a financial muscle. They do all these advertisements. How do you say that, oh, Charlie, the burden of non-communicable disease is high, alcohol is going this is going up, we have to control. How do you control them when they are legitimately registered businesses? They are employing your mother, your father, my brothers and sisters. They are paying taxes. The government is generating revenue. We don't see the diabetes. We don't see in fact, when you come to hospital, you're obese, you have malaria. I'll comfortably treat your malaria, go away with your obesity. We don't see those things. So I think it's important that we situate the profit in the larger context of public health. Oh, the product. You would think that we would have a pricing regimen where foods that were healthy will be cheaper than foods that were unhealthy. In developed countries, they have sin taxes or they have soda taxes. So if something was high in sugar, the cost is much higher Here, what do we find? The sugary drinks. Coca-Cola, when I was little, was as small as this. Now they are very giant bottles. The Total Packs, the whiskey, what do you call those? The gin, those spirits. They are made in small quantities so that people like you can easily buy and just put them in your pocket. And you don't, if you went to the shop to buy a bottle of wine, it's going to be much cheaper than if you had a small. So, and then the providers. Let me just rush through this. Now, the other point, Madam Chair, I'd like to mention is recently, I think last week, there's this talk about Ministry of Food and Agriculture suspending exports because of some fruit flies or something. And in fact, the minister is actually reported as saying that as for fruit flies and so on, we've lived with them, so it's not a problem. I think the issue has to do with the fact that when these things are packaged, I was talking about the private industry, but actually within the government itself, the emphasis is heavily on revenue. If it's revenue, we talk about it. If you are going to ban export, nobody talks about public health. And yet we also consume these leafy vegetables or selected vegetables. You wouldn't, I doubt that even Ministry of Health was involved in a discussion on banning the export. So there's a lot of emphasis on, as long as it is for export, we satisfy the requirements, we make every effort because we want to make money. Our public health is as if we are dispensable commodities. We don't make as much noise. If something is bad to be exported, it should be bad for us to consume them locally, but that doesn't seem to be necessarily the case. Okay, food and beverage industry, we jumped that. The 8th point is that it's important to consider the burden and causes along a continuum of care. What do I mean by that? It's very easy for us, especially clinicians, to focus on a certain part. We often forget that we are looking at a chain from where you are not exposed to a risk factor, you are now exposed, you don't quite have the disease, there's an early marker, you have an established disease, complications, you die from them or you recover. If you're looking at the burden, it's important to look at it along this continuum and not just think that you are static. It's always important to look at this as a comprehensive whole. Okay, the 9th point is that there are new and emerging lifestyles, particularly in urban centers. So with this one, the worry is about this shisha. So there's a nightclub, there's a shisha night, on Wednesdays, there are restaurants where it's just a shisha. There are clubs, there are buildings that you see on highways, it's just, you go and then you, as a group, you sit around and enjoy the flavor and just smoke all over the place. Today I heard something about the fact that the Ghana Health Service said they were worried about young girls doing this shisha thing. I think that is important when we're looking at the burden. Yes, tobacco as a whole is going down, but some of these practices are also emerging in our system. And then these advertisements on herbal medicine. When I was younger in a medical school, we used to think of herbs as bark, tree, raw. Now they are no longer like that. They are packaged, they are huge billboards, they use stethoscopes. In other words, they are being marketed just like orthodox medicines. And so it's not to say that herbal medicines are bad, but as you and I know that the regulation, we are not quite there in terms of how they are regulated. And sometimes we even push the advantage, apart from the multiple claims, and we even push that, oh, forget, don't take your insulin, don't take your drugs, moringa with moringa or dandelion or something, you are good to go. So I think it's important that the health minister recognizes that and says that critically monitor advertisements on herbal medicine. Okay, so my final point is that we have, from what I've said, I think that we have enough tools to be able to do something about non-communicable disease. And indeed, the WHO says that they have a list of what they call best buys. If we're able to do all of these, we'll be able to save 22,000 lives by the year 2025. Before I end, I'll just quickly run through that what were my messages. That non-communicable disease development, burden increasing, complications common, outcomes not so good, awareness low, younger people are affected, risk factors all over the place, major causes are not only in the health sector, that the burden is important to consider the burden along a continuum, and that there are new emerging lifestyle, particularly in urban centers, and we have the tools to act now. Ladies and gentlemen, Madam Chair, thank you very much for the opportunity.
I think we'll move straight into the next section.
Bristol University to do a master's program where he focused on health protection, including communicable and non-communicable diseases. He returned to Ghana, went back to Konfanoche, was made the head of public health. He built up the unit into an autonomous unit and led in the institutionalization of public health practice in the hospital setting, through the hospital setting, through strengthening of disease surveillance systems, training of clinical staff, and routine feedback on public health issues. He has also taught at the public health school. No, he has taught public health at the KNUST Faculty of Pharmacy and Pharmaceutical Sciences for the last 7 years or so. And he's currently the program manager for non-communicable diseases with the Ghana Health Service. He is leading a review of Ghana's policy and strategic plans for non-communicable diseases. So at least something is happening and somebody is in charge of it, and he is going to tell us something about it. He's also a fellow of the Ghana College of Physicians and Surgeons and has a number of peer-reviewed publications to his credit. Dr. Larry.
Thanking the Academy, first of all, for bringing this issue of NCDs up, but also for inviting us to be part of this presentation. So, mine is to talk about the changing nature of the problem and economic impact. I had to dig deep into my health economics base to be able to put some of these issues out. So briefly, this is going to be the outline of my presentation. We'll put a few things in context, and then we'll look at changing the issues that are changing in the country that have an impact on NCD. So life expectancy, lifestyle, the diseases themselves, complications, some of the issues. I think Dr. Bonsu has discussed some of them. We will also look at the increasing trend of complications in particular. I think he discussed that. And then we'll look at the management or treatment for NCDs. Because we're looking at costs, and those are the issues that bring the cost. And then we'll delve into the economic issues. So economic costs, economic impact. And hopefully I'll go away with a few recommendations following my conclusion. So if we talk about non-communicable diseases, I know Dr. Bonsu mentioned that there's still no political commitment, and that's true. The political commitment is still lacking. But we've moved from a situation where nobody spoke about NCDs. If you look at the UN Millennium Development Goals, there were 3 goals on the health, and none of them was explicit on non-communicable diseases. So at least it's receiving some level of high-level political commitment. The other issue is that if we look at funding, and a lot of our public health activities are donor funded. So for every 100 million we received for donor support, it's only about 1.2 million that goes into non-communicable diseases. And in a slide later, I'll show you the breakdown and the areas that we're focused on. Now, so this is in billions of dollars. So between 1990 and 2015, this is how much development assistance for health developing countries, so low and middle income countries, have received from the developed countries. And as you can see, I've highlighted NCDs in brown. So it's only 6.5 billion. Compared with HIV, for example, it's 115 billion. So even if you take out 100 billion, the 15 billion that's on the HIV money is still more than what has been put in NCDs for the 25-year period that we've looked at. If you look at the and as he said, it's either infectious disease or maternal and child health. So those are the key areas that monies have been spent in, and it's not surprising that we're seeing the kind of impact we're seeing for non-communicable diseases. So as I mentioned, the SDGs have looked at NCDs, even though there's only one goal for health. And Mensa-Bonsu highlighted the fact that a lot of the other sectors have an impact on SDGs. But even within the health SDG, you still have a lot of the objectives looking at non-communicable diseases. My favorite is the 3.8, which looks at universal access. So achieve universal health coverage, including financial risk protection, access to quality essential healthcare services, and access to safe, effective, quality, and affordable essential medicines and vaccines for all. Now, this is important for our particular topic. 3.4 talks about reducing mortality from NCDs, but for our purposes today, we're looking at issues of economic, and most of the things here, particularly financial risk protection, are critical. When it comes to NCDs, they are very important. The WHO, it used to be 4 major risk factors, but air pollution was recently added. So now we have air pollution as a risk factor for non-communicable disease. In addition to the physical inactivity and healthy diet, and I think I'm happy Dr. Bosu has mentioned some of them, and I'll add on so that we will be able to understand why these issues are there. Tobacco, probably not, but as you already mentioned, shisha is something that is coming up and we need to look at critically. So let's start with our changing lifestyles. Now, if we start with physical activity, it's changed. I mean, our level of physical activity is getting worse. So when I was a child growing up in Kutubabi, if you needed to take public transport, you have to walk from Babana Junction. These days, public transport is right there in the communities. So being physically inactive from ready availability of transportation is not the prism of the affluent who have cars in their homes. So now the people who are down the socioeconomic ladder are also physically inactive because commercial vehicles are right down there. They can have access to it right at their doorstep. Okay. So there are other things. If we look, for example, at our schools, there are a lot of international schools now, and I tried to get a survey to get proper evidence. But from what I have observed, you see, the sites typically will have a lot of space for physical activity. But the private schools that are coming up, you find that they are in maybe 2 blocks, and it's a whole school. So where are the children engaging in physical activity? And it's not surprising that child obesity is going up in Ghana. So physical activity is a problem. And then, of course, consciousness about the need of physical activity. So how many of us will park a car at a distance and walk to our offices because we want to be physically active? We don't. How many of us will choose to use the stairs instead of the lift? So yes, it's good to know that Prof is still physically active. But the truth is that we have alternatives now. In our shopping malls, there are escalators. So we are physically inactive. We drive to the mall and then we use escalators there. So physical activity is really gone down. Then the other issue is with alcohol use. So 17.5% of women aged 15 to 59, and then 36.7% of males were found to consume or taking alcohol regularly. And the capital consumption of alcohol in Ghana, absolute alcohol is 2.7 liters. So that means that for those who don't drink, some people are drinking for you, and then that average comes out to that. It's not surprising that it's happening in Ghana because I think somewhere in 2010 or 2011, we woke up one day and we were middle income. And then now the economy has been growing and we are projected to be the fastest growing economy in sub-Saharan Africa this year, which means that the issue of alcohol intake is also likely to go up based on the fact that there's a relationship between economic growth and the intake of alcohol. The other one is aggressive advertising, and I think that Dr. also again highlighted that. And we see all the adverts on TV, and we have to be, I think at least FDA has to make some rules, and now the adverts don't happen at the times that they used to. But the adverts are still there. There's aggressive marketing. The festivals, as you mentioned, a lot of social activities. In fact, in recent times, we know about one company that was banned because they sold alcohol to minors, and then after a few weeks or months, they were back in business. So the issue of alcohol is also quite critical, and it's a major risk factor for non-communicable diseases. So this is just a graphical representation of alcohol consumption per capita worldwide. So the other one is tobacco. Tobacco is not really an issue, but I think that the key thing we need to talk about is the uptake of shisha. And part of the problem is that whereas tobacco smoking or cigarette smoking is frowned upon, so if you find a woman smoking cigarettes, the tag that we put on that woman is very negative. But the same is not for shisha. So you find very young women, university students, sitting and smoking shisha in the open. That means that it's societally acceptable, it's attractive, because when young women are doing certain things, it's very easy for them to also get their males to join. Because if the woman is smoking, how can you, the man, not smoke? And I have a personal experience where I was going to Mensa-Bonsu when I used to work there. It was after Easter, and all the VIP passes were, gone because it was quite difficult. And I stood there. I never picked Ford because there was always this fear that Ford mini passes, they are dangerous and all. And I stood there for a while, and then I saw this young lady just confidently walk into the Ford, and then the bus was full, and she moved. Then stood there, I was like, so this young woman has boarded a Ford, and I'm sitting here and I can't board. So there's a way they can influence your uptake of these things, and it's very important that we take cognizance of that and make sure we report that. The other thing is unhealthy diets. And I put these two news items I found online because I think that tells us the whole picture. So whilst some are worried about the proliferation of fast food joints in Ghana, so somebody had this article, KFC opens another branch in Mensa-Bonsu. He's obviously worried about it. There's another one which says fast food chains we wish would come to Ghana. So he had a list. Of course, I didn't want to advertise any fast food chain, but I took them out. But I guess it means that some people are expecting, for those of us who have traveled elsewhere, we've seen some fast food. So once we see them here, we are thinking, oh yeah, we are also moving. So it's a sign that Ghana is moving forward. But I think that it has health implications, and we need to look at that. There are a lot of additions to our food, so salt, we talk about Maggi cubes and all those other salts that we add to our meals. It's quite common in Ghana, and we have the global food chains invaded, and I hear there will be more coming. But it's not just that. So our local, we have our own, the informal, the non-global ones, with the popular one being check, which is sold virtually on every street. We know. And they add a lot of salt, a lot of fat in the foods that they put, and these are very dangerous. The other worrying part is our resort to processed foods. So you see a lot of children being given sausage as snacks. I mean, sausage as snack, it's dangerous. This is processed food, high in salt, and all the bad things. So our food consumption is also changing, and that's a risk. The last one is air pollution. My favorite is the fact that Agbogbloshie is one of the most polluted areas in the world. It's in the top 10. Okay, and recently somebody told me when the issue of air pollution came out, there are people who walk on our streets every day, and our vehicles are not, most of our vehicles are white. And these are producing a lot of fuel. So what is the impact of these on these people? Most of our vehicles are white, I think I've mentioned. And then we have residential areas in the middle of highly polluted areas as well. So that's another risk which we ought to look at. changing lifestyle. Dr. Bonsu mentioned that in bed they have life expectancy equivalent to Europe. So we saw that reflecting in the proportion of deaths due to NCDs. That is what is going to happen with us as well, because our life expectancy has improved from low 50s in the early 80s to about 63 now, and it will only get better once our health system gets better. People get access to treatment, infectious diseases go down. So these are the issues that we ought to be looking at critically. And in the demographic and health survey, you can see clearly that as the age increased, the proportion of the population that had high blood pressure also went up. So age is a risk factor for several entities, and we need to look at them. We would have wished that we transitioned from infectious diseases to non-communicable diseases. And unfortunately, we are living with a double burden. So we haven't completely won the battle against infectious diseases and non-communicable diseases are rising. So that's another issue that we need to look at. This is similar to what Dr. Bonsu presented, but it's just looking at them in terms of representation based on color. This is in 1990, we realized that most of these here are infectious diseases. And in the 1990s, they accounted for a significant proportion of the deaths were reported. As you can see, it's almost balanced now. So that means that there is a change in the diseases that are killing us as well as a population. So what are the implications? The other one is the complications. So 47% of patients with high blood pressure who were being seen in hospitals had a certain stage of chronic kidney disease. And stages 4 and 5 will mean that they need dialysis or a kidney transplant. And these are very expensive, and I think I won't belabor that point because Dr. Bonsu mentioned it. The other key thing about non-communicable diseases is the management. So the long-term treatment is key, particularly for the chronic ones. But also you need multidisciplinary teams. So you can't just have one person just give you the treatment and go. Depending on the kind of NCD it is, you can have a very simple team of, let's say, just a doctor and a nurse and a pharmacy technician to look at. And then, of course, the other one is equipment and logistics. Malaria, you can just do a little break, put the blood drop on a to look at. And then, of course, the other one is equipment and logistics. Malaria, you can just do a little break, put the blood drop on a little stake, put it, observe for a few moments, whatever change happens, you can make a diagnosis of malaria. You can't do that for most STDs. So you need sophisticated equipment to make these diagnoses, and those also come with costs. So let's look at the economic costs. I know in the earlier discussions I've highlighted some of them and tried to get to them, but let's look at the direct costs. So these are the costs the person is making or incurring because he or she has a non-communicable disease. So if the person goes to the hospital, they need to pay a consultation fee, they need to pay for laboratory tests, the medicines, the HACCP admission, that comes with a cost. We're not looking at who's paying, we're just saying that all these costs will be incurred. If they need surgery, they need to, and if they are moving to the health facility, they have to pay for transportation. Whether they use their private vehicles or they go by public transport, it's still a cost that they are going to incur. And then indirect costs. So we look at loss of working time. For those who work, so the person with the disease condition himself may lose working time, or if the person is being cared for by somebody, so somebody will say a stroke. If the person is going to the hospital, then they might need to go with somebody. So that person is also going to lose working time. So the loss of working time is not restricted to just the person with the disease, but if there's somebody who's taking care of the person, then that means that that person is also going to lose time. And then loss of income. So it's not everybody who is entitled to sick leave. For example, some people, particularly those who are casual workers, if they don't come to work, they don't get paid. So if you have an NCD and you need to go to hospital or you get admitted, then that means that you are not likely to get paid because you have the disease condition. And that is a loss of income. And again, it applies to somebody who is a caregiver as well. Consider the person is also giving care, then that means that the person will take some time off work, and that may result in loss of income. There is loss of productivity itself, so that may result from a disease condition, the side effects of the medicines the person is taking, for example, or any other complication that has come as a result. So some people sink into depression, for example, because they have an NCD. And depression has been found to reduce productivity significantly. So this is also a cost that is going to be incurred by a person with an NCD or a caregiver for a person with an NCD. And these are some of the indirect costs. Now, let's look at the economic impact. So, I'm sure it's clear to us that NCDs are very complicated. The risk factors are several, and controlling the risk factors, some of them are within your control. For example, you can decide that you will walk and not use your vehicle. But can you decide the air quality around you? Can you decide that, you will regulate the kind of advertising that is going on airways about certain things? So some of the things, the impact in terms of economics can be very complex, and I think the WHO has acknowledged that that can be quite complicated. And a colleague from Ghana has also done a study and highlighted the need for further studies to be done in the area of economic impact. But there are other issues, for example, the perceived need for immediate response to infectious diseases, for example. The case fatality rate for non-communicable diseases. You see, when there's Ebola, the statistics goes out there quickly. The case fatality rate is 50%. Then we turn it and say, so for every 100 people who get 50 will die. That sounds big. But we walk around with people with high blood pressure. You don't hear that kind of sensational issues about our NCDs. So we have to put these in context. It's normal to know somebody with high blood pressure. It's not normal to know somebody with Ebola. So why is economic impact critical? Because we don't have the privilege or the benefits that come with infectious diseases, where the politicians will respond because they are afraid or people are dying. The pressmen will take it up. 3 people die from cholera. It's in the news. And then you start getting the phone calls. So we need to find very good ways or innovative ways of looking at the issues of NCDs. And I think that economic impact is one way we can be able to do this, particularly because the decision makers like to look at numbers. We can go and stand there and talk about dialysis, equipment that are expensive. They need to actually be able to make an economic sense out of all those issues we are putting across. So I think that the best buys Dr. Bosu mentioned are critical, but we need to make an economic argument for those best buys. And I think that there have been some studies which have looked at the economic impact of NCD. So if we look at lower middle income countries, they are projecting that between 2011 and 2025, $7 trillion will be spent or will be lost as a result of NCDs. That's an average of $500 billion. Now, if we look at the best buys, the interventions, that will translate into spending about $170 billion in the same period, or $11 billion per annum. This is for all low and middle income countries. Okay. The other thing is that 100 million people are set to be driven into poverty as a result of the impact of NCDs on household income. Poverty is one of the things politicians don't like. So across both parties, we know that there's a lot that they are doing to reduce poverty in this country. And in fact, in the MDGs, I think it was one of the few indicators we were able to make progress. But once NCDs go up, and that means that people are going to be driven into poverty. And I don't think that that is something we want to look at. So on the households, we have issues such as loss of livelihood. So people, for example, if a household member dies, and that means that the person is the one who was the highest income earner or highest income in the family, and that is lost. they can also reduce household income because some of these treatments can be very expensive. So that means that they will have to utilize their savings, for example, sale of family assets, they would have to borrow, they will have to slash the expenditure. So, for example, if a child is in an international school, maybe they will have to resort to sanitary aid. Not in any way to say that it's bad, but that is because of the impact of the economic cost on the family. And then poverty. So the danger with NCDs is that whilst it's a risk factor, poverty is a risk factor for NCDs. NCDs can also result in poverty. So it's like a double barrel gun. It's going to really be a problem for families. And once the EA found that households where somebody has an NCD, they spend 49% more on their health expenditure than a household without NCD. Now, on our health system, the basic thing is that, first of all, our health, our spending on health is low. It's below what the African countries agreed to do. The Abuja Protocol, it was supposed to be 15%. In 2018, our budget allocation was about 6.5%. So that means that we're still spending less on health. And if we're spending less and NCDs go up, then that means that it's going to put further strain on our already strained health expenditure. And I've mentioned the several cost implications for NCDs, from the human resource to laboratory investigations to the cost of treatment and the long duration of treatment. The other thing is that for every 10% increase in the incidence of NCDs, it's projected that it will result in a reduction in the annual growth rate by 0.5%. So if it is projected that our growth rate, economic growth rate next year is going to be, let's say, 8%, then if we factor in NCDs going up by 10%, then that will have to be revised by 0.5%. So if we happen to grow 8.8% that year, what it actually means is that we would have grown 8.5%. Okay, so that is an issue we need to look at. And there's evidence from China and India and other South American countries about the economic impact of NCDs on the gross domestic product. Of course, if we talk about industry, because we have a lot of institutions that also take care of their staff, it's going to come at a cost to them, particularly for healthcare costs, but also on productivity. And if their staff are not productive, then that will mean that their financial fortunes are also likely to go down. So in concluding, I think that there's obvious change in several risk factors for non-communicable diseases in Ghana, which means that if the change in the trend continues, then our disease burden can only go up. The other issue is that the cost for managing NCDs is high. Their direct costs, the indirect costs are also quite high. The access to treatment is limited by several factors. So I mentioned that human resource is not really available. So that means that the cost will be more. For somebody living far from any of these health centers where they can get access to treatment, it's going to come at extra cost. Out-of-pocket payments for NCDs will also be very high. Currently, the National Health Insurance Scheme, only about half of the population is insured, which means that if you think about the fact that not all non-communicable diseases are covered by health insurance, and we have so many also not under health insurance, then quite a significant proportion will be having to resort to out-of-pocket payments. There's a strong link between poverty and NCDs. I think that has been made. And the economic impact across all spheres is quite significant. The much cheaper cost is associated with prevention rather than us resorting to treatment. So I have a few recommendations. Okay, Ghana is spending more on NCDs with implications for investments in the other sectors. I think that is also very important. If we spend more on health, it means that we'll get to something. And even if it's on health in terms of prevention, that's good because in the long term we benefit. But if it's on treatment, investment, then it's not going to be beneficial in the long run. So I think we need to look at incentivizing things that focus on prevention. So all the issues about, for example, enforcement of regulations on things that deal with NCD prevention, tobacco, alcohol, the sugar sweetened beverages, which a lot of people think is safer than alcohol, not necessarily the case, because they all put you at risk of one NCD or the other. So they are not entirely safe. But we need to look at incentivizing things that make people healthy or prevent them from getting NCDs. The other issue is taxation, and I know taxation is a political issue, and also the fact that there are very strong lobbyists in the area of taxation, particularly for alcohol and tobacco. But we need to pull the bull by the horn and look at it. And then, I know I'm going to be in trouble for suggesting this, but should we subsidize fuel or healthcare? We need to ask that question, because whichever we look at it, it's money for the country. So do we want to get free fuel, and when we are sick, we have to the kind of treatment we receive, we base on how much we can pay. We need to start having this discussion.
And the last bit, social health insurance. I know we have a national health insurance which is designed to be social, but from what we are experiencing, it hasn't gotten to that point where people can access health care in the way that we will want it to be. People do not have to pay at the point of need, and that includes managing non-communicable diseases, and most of them are currently not covered. So I think that we need to look at that issue critically as well and see how that can deal with our NCD burden. I think I'll end here. Thank you very much for your attention.
My name is Malik Majuri. I'm an environmentalist. I have just two quick questions for the second presenter. With respect to depending on donor funds, you just made mention of even health, that it's coming from donor agencies. Is there any way that the government or through the Ministry of Health can develop their own way so that we can be self-reliant when it comes to that aspect? And two, with respect to the skewed distribution of doctors, I just want to ask a personal question. When Cuba, Fidel Castro wanted to redistribute the doctors, most of the doctors left the Havana because they were not happy. So if it comes to the government deciding that all the health workers that are in Ashanti region and Greater Accra, some should move, I want to ask the doctor, will you yourself go? Thank you.
Thank you very much. I think the donor issue is not restricted to only Ghana, but that's why I put some of the suggestions there. We need to be ready to fund our health system ourselves. Sometimes we politicize the issues, so when taxes have to go up, or we need to put in certain measures to make sure that there's revenue to be able to manage our health, there's always an issue. And that's why I put the tricky question there. As far as I can remember, from 1992, every year, fuel prices is an election issue. And it hasn't gone away. And I don't think we've been satisfied with what is going on. But I can say for a fact that we are all not happy with our health system. I don't know anybody who's very confident or happy with how our health system is now. You know, you walk into a hospital and you're confident that you get seen and on time, and if you need any labs, you don't need to move to a private place to get the labs done. Everything is working within the facility you are in. So I think that we as a people must first of all agree that health is a priority, and then those bitter pills we need to swallow to make sure that health becomes something we pay for without having to pay at the point of need. So if it's taxation, if it is making sure that things like alcohol and tobacco and sugar sweetened beverages are taxed, and these monies, I dare say, should also be sent into health, because I know sometimes the money is collected, but it doesn't necessarily get to where it is. So there are a lot of things. We need to prioritize health, and once we do, and we make the efforts to make the necessary financial investments in health, then we are likely to see that. Personally, will I move to, I have actually worked in rural areas before I got to Accra anyway. I've only been in Accra for, well, 2 years, and then my 2 years in 37 military hospitals. So I don't consider myself somebody who has spent most of his working life in an urban area. But I think that the issue of skewed distribution, we need to look at it critically from the push and pull factors. So why are people in Accra? I have worked in a district where sometimes you are the only doctor and you work 24/7 and you get paid the same salary as your colleague in Accra or Kumasi who is doing an 8-hour shift a day, and when he goes home, he's gone. He's closed for the day. He can go and do locum somewhere and make extra money. So do we want to incentivize people who go to those areas? Do we have to make it unattractive for people to be in the urban areas? I know there are certain measures that are the Ghana Health Service, for example, in the recent posting of doctors, there were regional allocations and the numbers were fixed. So if you got to the region and it was full, you need to go for an alternative. And even at my level, I've had people call me and say they didn't get Greater Accra. Can I help them to get it? So I know it's tricky, but we have to look at all the issues holistically and deal with it. Because as people keep saying, you never know when you are going to be a patient in some place where there's not a doctor. And again, I have a personal experience. I had an accident on the Accra-Kumasi Road. I was sent to a health center. There's a community health nurse who took care of me. So we need to look at it holistically, and I'm sure that we can be able to deal with that. Thank you.
Thank you. My name is Asante, Nana SKB Asante. I'm asking this question primarily on behalf of my people in the rural areas. It has to do with managing hypertension. I've often asked some of my people why they're not taking medication. They take medication for some time and then they stop. Why? They can't afford. You told us that some of these communicable diseases are not covered by insurance. Can you explain fully what this means, why we can't have affordable medication for people with hypertension, for example? Thank you.
Thank you very much, Nana. So it has to do with my very last issue, which is the distribution of human resource. So there are some, and this is medical practice. My senior colleagues here, Prof. Plandreau is behind you, Professor Akosa is here. Some of the medicines has to be prescribed by a doctor. So by virtue of the fact that there's no doctor there, you just rule out people's access to treatment. That's why I highlighted the fact that the distribution of human resources is critical in managing the issue of NCDs. And hypertension, not to underestimate the risk that comes with the disease, but it's probably one of the simplest non-communicable diseases. So if we can't have access to its treatment, for most of our rural areas, like you mentioned, there are still districts in Ghana with one doctor. So that means that automatically that district doctor is in the district capital. So all the other communities there, no matter what health facility they have, CHIPS compound, health center, they can't have access to treatment. And then the other part is that our National Health Insurance Scheme would only accredit facilities based on human resource available. So whereas a physician assistant in the hospital can prescribe antihypertensives because there's a doctor as the overarching clinician, the same physician assistant, if he's moved to a health center without a doctor, he cannot prescribe. So those are the system issues we need to look at. And Prof. Plandreau and colleagues, and I think there are other similar studies going on where they are looking at task sharing so that lower cadre of human resource can manage some of these diseases, but I don't think we are there yet. For me, I think the critical thing now is that we have enough doctors to go around the country. It used to be only KNUST and Kolebu. Now we have, I think there's a Faith Medical School. There are 2 private medical schools. There are countless foreign trained doctors. And when I got on the Medical and Dental Council register, I think there were about 2,000 doctors. Now it's more. It's much, much more. So if we take proactive measures to distribute the human resource, I am sure that people in the rural areas can also have access. It doesn't have to be doctors being in every town, but we can even have a system where, you know, they can run clinics on certain days in certain facilities, and that should also work. But I think that this will depend on all of us getting our politicians involved. I think the academy is also in a very good position to make a case for dealing with the issue of maldistribution of human resources in the health sector.
Okay. I just thank you very much, Nana. I just wanted to add 1 or 2. Okay. Hello. Okay. Now, for the compliance with medication, a number of studies have been done, and I think one recently that was done involved Dr. Safo Planju, look at Betifi Hospital and Confanochi and all that. And the old studies also, there wasn't much difference. I think what emerges strongly when it comes to compliance, I have 2 issues. Having to take medication is difficult, especially to take it for life. I mean, it's very easy to forget. Avoid certain unhealthy diets, tobacco, harmful alcohols, and all that. The last point I'd like to say is that medical, when people need treatment, it's often the case that we don't necessarily use the generic drugs. We like to use the drugs that have the big names. And then we combine various drugs and they tend to be expensive. And so costs a huge element. And our national health insurance struggles to cope with that.
Hello. My name is Jerry Koye from University of Ghana, Lagos. My question goes to the first presenter. Concerning the risk factors for non-communicable diseases, I didn't hear you mention genetic factors. If you could please throw some light on that. And then secondly, concerning the malignant neoplasms, I want to know what's the incidence of colorectal cancer in Ghana. Thank you.
Taking the last question first, I have to look at that. I don't have the figures in my head. It's one of the cancers I showed on the page. It's one of the top 10. I don't have the figure. If I pull up the slide, I'll be able to. And you are talking about breast cancer, prostate cancer, colorectal cancer, Okay, with regards to the genetic factors, I think the one I was mentioning the risk factors for diabetes. Now I showed some list and I mentioned that family history of diabetes was a risk factor for diabetes. I didn't mention the quantities, but I did mention that people who have a family history have a higher risk of having diabetes. It also many of the non-communicable diseases, certain cancers, hypertension, cardiovascular diseases. But because often these are not modifiable, you know, we're talking about age. Usually things like the genetics and age, you can't do anything about age. So we tend to focus more attention on those things that we can do a bit more about. Well, sometimes some people do something about the life, where there's a family history. There are radical cases where Professor Craig may tell you, they have something they call the prophylactic mastectomy, where even Angelina Jolie, the film actress, did it. But I don't think it's something that is recommended as a policy that if you have a strong family history and there's a risk, you go and remove your breast. So yes, there are family, the genetic factors are important for non-communicable diseases. Thank you very much.
Thank you very, very much.
I believe I represent you if I say a big thank you to the two speakers. Between the two of them, they have told us what the incidence of the NCDs are and what can be done and the increasing burden. In this country, we tend to believe that it is witches who cause the sudden deaths, and so we don't investigate the deaths. But the two speakers have pointed out that when these diseases occur, sometimes you don't even know. They showed us statistics of those who are not even aware that they have them. That means that we have to be vigilant in our health. And for the younger people, they told us about the lack of physical activity and healthy diets coupled with aggressive advertising. Now, sometimes I worry about some of our young children who eat too much. They have barely digested breakfast before they start snack. They carry all kinds of big pouches to school, eat snack, eat lunch, eat afternoon snack, come home, sit in front of the TV, eat a big meal, and it's not surprising at all that we have childhood obesity increasing. We need to do something about that. For those of you in high school, boarding school especially, you think the things in your chop boxes are better than what is given you in the dining hall. Maybe so, but I suggest to you that what is in the dining hall is probably more nutritious, even if it doesn't taste as good. So those of you who skip dining hall because your chop box is full of garlic and chicken and so on, you are killing yourselves. Go and eat what is not nice. At least the walking to the dining hall will be helpful to you. These days, at every corner you can find a vehicle, and now you don't even need to stand at a corner to call an Uber. So while we have all these lifestyle changes or improvements, there are also the downsides. We are not exercising enough. We are eating too much sugar, too much salt, and if we roll in a bit of religious fervor, then we won't touch anything unless it has plenty of sugar and it can call itself suffering. The result of it is that we are killing ourselves. They've also pointed out the economic costs of the burden of NCDs. Sometimes we look at the direct costs, the medication and so on, but when he drew attention to the indirect costs, that sometimes the carers also incur some costs. They can't go to work because they have to care for an ailing family member and so on. And all of these things are expensive. So when it comes, you have to live with the expense. So perhaps, as the last speaker pointed out, prevention is cheaper. Can we do more in the area of prevention so that we don't increase the burden, so that the correlation between economic prosperity and the disease burden can be broken, so we can be healthier even as we are getting richer? They told us a lot. We have a lot of food for thought, and I suggest, especially to the younger ones, that you should pay attention to some of the things you have heard tonight. They talked about how a family situation changes because the breadwinner has died suddenly. We know the phenomenon of from Dada to Bosa, don't we? And if it is, if that is produced by non-communicable disease, then it means they are the real enemy, right? They can change our lifestyles overnight. And we may be in school now, but it may make the difference between your being able to go further in your education and you're having to cut it short in order to find something to eat for yourself, and particularly if you are an older child in the family and there are younger children. You guys might find you can't go as far as you would have liked to because you have to help them look after. And if we have non-communicable diseases to bring, then we all have the responsibility to attack these diseases and to get our politicians to give attention. They both complained about politicians not giving enough attention. And then I was thinking, every time I hear these lectures on health, I suddenly begin to feel little pains somewhere. I don't know if you experience that. I suddenly, and the more dangerous the disease they talk about, the more I kind of start feeling that I'm beginning to get it. So I'm not surprised if other people feel the same, then it will explain the silence and the pretense that it doesn't exist. But perhaps pretending that it doesn't exist is not the way. Even if we don't like it, we should confront it so that we have a healthier generation able to sustain the prosperity that we are all working towards. I thank you.
Shall we continue clapping for the children? Thank you very much. We would like you to notice that tomorrow is another day. This public forum is for 3 days. We've had the first day. Tomorrow will be on established and emerging non-communicable diseases. We'll have a talk on hypertension, the silent killer, cancers, and the mental health. And on Wednesday, we'll have the social and institutional responses. This will be wellness and lifestyle changes and redesigning healthcare systems. Please, shall we all plan to be here so that we have the full package? Thank you very much. We would like to acknowledge the presence of the following schools: Accra Academy, Accra West Eagles, ATTC, Accra College of Education. Shall we please clap for them? We have come to the end of today's session. Please let's rise as the party here on the front.